Hi, this is Dr. Bhargava. In this short video, I'm going to show you two VQ scan pitfalls. Here is a VQ scan that was submitted for interpretation by the nuclear medicine technologists. The ventilation images are in the top two rows, followed by the perfusion images in the bottom two rows. And I want to direct your attention to just the anterior and posterior of ventilation and compare them to the anterior and posterior of the labeled perfusion images. What you will notice that there is a striking similarity between the two. Also, that perfusion images show some soft tissue activity not seen on the ventilation images, but they're very similar. And that's what prompted us to investigate further as to why the ventilation and perfusion images are so similar. And so typically when we do VQ scan using technetium-99m DTPA aerosol for ventilation and technetium-99m MAA for perfusion, we want to do the ventilation first, followed by the perfusion. And when the ventilation is performed with technetium labeled DTPA, the dose used is 30 millicuries in the nebulizer, and after a patient inhales it, about 1 millicurie gets deposited in the lungs. This is followed by a 4 millicurie injection of technetium-99m MAA to overwhelm the ventilatory activity from DTPA, and perfusion images are acquired in same standard 8 planar images. So since these images looked the same, we repeated the perfusion, and this is what we found. Ventilation images are the same as before, right? Nothing has changed there. But look at what happens to the perfusion images. They are much better now, showing a pattern of perfusion much better than ventilation, and some reverse mismatch defects in bilateral lower lung zones where there is perfusion but absent ventilation. So this patient has ventilatory abnormality like a mucus plug or bronchoconstriction, things of that nature. So here what happened was that the first time they wanted to do perfusion, the dose got infiltrated and they weren't paying attention to the count rate on the perfusion studies. And what we see on the perfusion images, or the images that are labeled perfusion, is just ventilatory activity, right? So when these two images look very similar, you have to doubt whether the scan has been performed correctly, the radiopharmaceutical has been injected correctly, right? So this was we had two such cases, and we were able to publish this as a case report: recognition of dose infiltration on pulmonary ventilation perfusion scintigraphy. That's one pitfall that I want to draw your attention to in this video. And here's the second one. So during COVID time, a lot of centers decided doing perfusion only studies, and we didn't want to do ventilation because of the COVID precautions. And also we know from myocardial perfusion imaging that the stress only protocols are very popular. When the stress myocardial perfusion images are negative, the resting part is not needed. Similarly, when we started doing VQ scans in that fashion where we only would do perfusion, if the perfusion scan is normal, ventilation is not needed. And so some centers moved to that protocol where perfusion is performed first, and if the perfusion is negative, ventilation using technetium-99m DTP is not needed. So this is an example of that, where perfusion images were acquired first. And again, I want to draw your attention to the anterior and posterior images. There is a segmental wedge-shaped pleural-based perfusion defect seen in the right lung, right there on the anterior image, and right here on the posterior image. Now this can very well represent acute pulmonary embolism, and we need ventilation images to correlate. So in this situation, after you have injected patient with technetium-99m MAA, when can you perform a ventilation study using technetium-99m DTPA, right? So that's the question. So here the technologists perform the DTPA the same day, and they put about 25 millicuries in the nebulizer and perform the ventilation, and these are the images. And so looking at the images, anterior and posterior images labeled ventilation, but they're showing perfusion activity because this ventilation was repeated the same day when the lungs have 4 millicuries of technetium-99m MAA. In this situation, you want to wait for 24 hours to let the perfusion activity decay and then do a ventilation. So this is the second pitfall that I wanted to share with you. Attention to detail in nuclear medicine procedures is very important, and if we don't pay attention, then we get into the situation of what they call garbage in, garbage out. We may not know what we are missing or how we are adversely affecting patient care. And so it may not take much time to move from nuclear medicine to unclear medicine. Thank you for watching.